Arun sir, we are good to go.
Arun, are you ready?
Yes, sir. Yes, sir.
Okay. Okay.
Can we start, sir?
Yes, yes.
Okay. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಹಬ್ಬದಂತೂ ಸಂಭ್ರಮ ನಡೀತಾ ಇದೆ. Festive mood has already created in celebrating Varmahalakshmi, invoking the blessings of Goddess Lakshmi and inviting her to home. But Thursday, it's already calendar marked date, after which KCOG has started academic wing. So Guruvina vara adu. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namaha. Which means the teacher is indeed the primordial, omnipotent God, and my pranams to all teachers so venerable. They say good teacher explains, superior teacher demonstrates, great teacher inspires. With this, my pranams to esteemed OBGYNs of Karnataka, College of Obstetrics and Gynecology. Today, 24th August, a platform is created for the topic of discussion about critical evaluation of tubal factors of infertility. Sounds so simple, yet has its vital role to play as a channel, as a connector to uterus and ovary. A tube which is 10 to 13 centimeters long, 0.5 to 1.2 centimeters in diameter, allowing the motility of sperm and ova with its rhythmic contractions and environment-friendly fluids, which is as explained by Gabriel Phaloppus in the 16th century, with his exhaustive dissection observation made during the dissection of human cadaver. So looking forward in this platform of academic wing of Kasoga KCOG, I welcome all mentors and seniors of our fraternity, all consultants and postgraduates who have logged in. My due respects in welcoming the pillar of Kasoga and KCOG, Dr. Hiremat, Chief Patron. Thank you, sir. Welcoming ever-smiling beauty with brains, Dean of KCOG, Dr. Hema Divakar, is a pleasure. Ma'am, thanks for logging in.
Thank you.
Ever supportive and favorite of postgraduate, Chairman of KCOG, Dr. Muralidhar V. Pai. I think sir will be joining in a while. Special welcome to our COVID past president of Kasoga, now the vice chairman of KCOG, Dr. Baswaraj Sajjan sir. I think he'll also be joining in a while. Ever-loving Madam Dr. Vidya Bhatt, Secretary KCOG, we welcome you, Madam. Our dynamic president of Kasoga, Dr. Vidya Tobi, special welcome to you, Madam.
Thank you. Thank you.
A pillar and connect to all committees of Kasoga is now the secretary, Dr. Rajashri Paladi. I welcome you, ma'am. Ma'am, I think we'll be logging in. Yes, I don't see her on screen. Okay. Welcome to Dr. Bharti Rajshekar. Madam, in advance, congratulations. Yes, you're muted, ma'am.
And keeping my fingers crossed.
Thank you, ma'am. And today highlights the speakers, Dr. Sunita TH, Dr. Mahesh Koregal, Dr. Shilpa. A warm welcome and best wishes for your presentation. Thank you so much. Now I request Mr. Arun for a virtual lamp lighting.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Mr. Arun. I now request Dr. Rajashri Paladi to introduce our moderator for today's session.
Vidya Tobi's talk.
Yes, sir.
You ask President.
Yes, sir.
Address.
Madam Dr. Vidya Tobi.
Yes.
Yes, madam.
Namaskara,
Welcome.
everyone, and happy Varama-Lakshmi, which is coming tomorrow. So, as Sonia told, it is all festivities, but we are into the academic festivities of Kasoga. Our academic wing, KCOG, is shining today. Today, so many stalwarts have joined, and today the important Tubal factors in infertility, the critical evaluation is going to be discussed by our none other than Dr. G. Remat, and everybody will be interested in this topic, which is relatively less talk. We always talk of ovulation, ovulation induction, ovulation protocols, but we have this discussion. And Dr. Sunita, Dr. Mahesh Koregal, as well as Dr. Shilpa, who is infertility chairperson, and our EC member Mahesh Koregal and Sunita TH, these are our panelists. So let us enjoy this academic feast today. Over to our sir, Dr. M.G. Remat sir, to moderate the panel and to introduce him and tell something other than this introductory talk. I think Dr. Rajeshri Palladi is not there. So over to our Sonia Mandapa. Okay, thank you very much. Thank you.
Sonia, brief.
Thank you very much, madam. Arun sir, can we have a CV of pillar of Kasoga, who needs no introduction?
Now you can introduce without CV. Okay.
The introduction with this flyer, which is very catchy flyer, though it is black and white, sir, you've made it very colorful with the speakers you have interested the topic on today. It's my privilege that I am here to introduce and share this CV of Professor Dr. M.G. Remat, who is the favorite of all postgraduates. He is the present principal of KLE JM Medical College, Hubli, academic council member, the Dean University of Belgavi, chief patron and founder secretary of Kasoga, who is the president of Rangavaidyaru Culture Association, Hubli, former director of KIMS Hubli, director of Hatch IVF Center, Hubli, and ex-chairperson of Breast Committee Foxy, as well as past vice president of Foxy. And he was the past president of Kasoga, a Senate member of Karnataka University, Dharwad, and the past president of the Club of Vijayanagar, Hubli. Just to complete the list, yes, a recipient of Million Fellow Award for Excellence in Academics of Foxy, which is very, very important for we youngsters to note that this was an achievement award in 2000. Over to you, sir.
Good evening to everybody. President of Kasoga, Dr. Vidya Thobi, Dean of KCOG, Dr. Hema Divakar, all the esteemed speakers, and lovely moderator, the program moderator, Dr. Sonia, who has contacted each and everyone and made everyone to come on the program. At the outset, I would like to clarify, as rightly told by our president, that too much of infertility has been talked only on ovulation. The tubal factors have not been discussed for a long time. So I thought that let us have some light on the tubal factors, because that is also very, very important. Now, yesterday we enjoyed landing of the Chandrayana on the moon. Now it is, I think, quite corroborative to the infertility problem. The uterus is like Earth and the ovary is the moon. Now the fallopian tube is the Chandrayana, and it is doing all the job what a Chandrayana is doing today. But unfortunately, we are neglecting this organ very much. And to just begin our session, I request Arun to put up this photograph. I dedicate this scientific program to this great man, none other than Gabriela Fellow. Gabriela Fellow, a very well-known anatomist from Greece, and he did dissection of various organs. And out of that, the fallopian tube is one. All credit goes to him, and he gave the total anatomy of the fallopian tube and functional nature of the fallopian tube. And you know that, as rightly told by Sonia, fallopian tube is a very small structure in the pelvis, having just a length of 10 centimeter. 0.25 to 0.5 is the lumen, and it has got 4 divisions. One is the one which is embedded in the uterine wall, another is the isthmus, then is the ampulla, then is the fibria. All these 4 divisions have got a specific work, like our arbiter, like our the lander and pregna. Each one are doing such a wonderful work, and without their work, I don't think any woman can become pregnant. Such is the beauty of the fallopian tube. And anatomical, the magnanimity has been already reached, but it is unfortunate that till today, we have not understood the function of the fallopian tube very well. And fallopian tube has got so many functions, like picking up the ovum from the surface of the ovary and transporting it to the fallopian tube, making it to join with the spermatozoa, then the form an embryo in the ampullary portion of the fallopian tube, help in the early development of the embryo for a day or two, then transport back into the uterine cavity and put it in the uterine cavity. Such a wonderful function fallopian tube does. But unfortunately, we don't have a single test which will test the function of the fallopian tube. Whatever critical evaluation today we are discussing, they are all only telling the anatomical integrity of the fallopian tube and anatomical function of the fallopian tube, whether the tube is patent or not. The patency of the tube is alone is not enough to do the function in the infertility. Function of the fallopian tube has to be evaluated, but unfortunately, we have no any test to identify whether the fallopian tube is functional or not. But great work has been done by Rubin. And when we were postgraduates, Rubin's insufflation test, carbon dioxide test, was the only test for almost for a decade. And that test was so rude. And you keep the cannula into the cervical and connect it to a manometer of carbon dioxide, and you put the carbon dioxide, and with a stethoscope you hear in the iliac fossa hissing sound. And you know how difficult it was to do a hissing sound, and more than 50% of our test used to be wrong. Then the development of various investigating procedures came into the picture, and in that, I think probably the best evaluatory breast critical evaluation can be done laparoscopy and hysteroscopy. But however, we can't do a laparoscopy, hysteroscopy to everyone in the very first visit, which is very costly and which has got so much of difficult procedure, skill is needed. Then earlier to that came a hysteroscope, the HSG, hysterosalpingography. That was also involving multiple. When I was a postgraduate, the most difficult job was for me is to go to radiology department with all the speculum, tenaculum, dye, everything. Radiologists never used to indent these things. It is only postgraduate should go to the radiology department and do everything. And ultimately, many a times, the X-rays used to be not so clear. Then we are thinking whether is it worth doing. Then in the year 1990 late, World Congress on Fallopian Tube was held in Mumbai. I hope Hema Divakar will remember that we attended that conference for 3 days. In that World Conference of the fallopian tube, a evaluation critical can be done even in OPD basis by using a sonography. Then the sonosalpingography came into picture. And apart from sonosalpingography, hysterosalpingography, and laparoscopy and the hysteroscopy, the falloposcopy has also come into the picture. Today, we don't know how much time we have to discuss all these. And today, I have selected 3 experts in this field. The none other than Dr. Sunita T.H., Dr. Mahesh, and Dr. Silva. You know why I have selected these 3 people is, these 3 people are very close to me. Dr. Sunita was my postgraduate student in KMC, and we did together her thesis, that is sonosalpingography. We did 200 days of sonosalpingography. And Sunita will tell in her presentation how difficult it was to do every time. But ultimately, when we did this, and also at the same time, in the Sion Hospital of Mumbai, they also took up this project. And this was for the first time, more than 200 cases presentation was done in the All India Conference. And people appreciated that how simple it is. And if you do meticulously, how it can help without wasting much of the money, without putting the patient into much of the trouble. Sonosalpingography is one of the evaluation which we are going to discuss critically today. Now, second, we are going to discuss is the hysterosalpingography. Dr. Mahesh will discuss, and ultimately the laparoscopy, hysteroscopy also will discuss in detail. Now, why we are thinking that the tubal factor is in every infertility evaluation, we don't evaluate tubal factor in the beginning. We think of tubal factor only after some time. Suppose somebody has come with married life of 2 years. We always think of the other factors, like is it a cervical factor? Is it a uterine factor? Is it a immunological factor? Is it a ovarian factor? Today, more and more has been put on that ovary is evaluated too much and ovulation induction is done very much for every patient. So when we are doing this, the tubal factor is also equally important. At one stage, you have to go for the evaluation of the tubal factor. And why I'm telling that go for the tubal factor evaluation, the fallopian tube obstruction is the infertility in a quite a good number of. Now, why does the fallopian tube gets obstructed? The common cause for obstruction is salpingitis. You know, though tube is situated in such a place, it is very difficult to reach the tube either through the cervical canal and uterine cavity or through abdominal cavity. But however, all these two routes can infect the fallopian tube. Endosalpingitis is the main cause for producing the block. The block may be partial, block may be complete. It is the endosalpin which is the cause for that. That's why my request is that in every woman when they come for infertility, please look for infection. Do a pelvic examination, take a smear, take a swab, treat infection. Infection is the #1 cause for that. Endosalpingitis, maybe a sexually transmitted disease or maybe a non-sexual. But today, the chlamydia and mycoplasma are the leading causes of tubal disease. And these chlamydia and mycoplasma are such an organism, they damage the mucosa of the fallopian tube. See, in fallopian tube, it is not just the wall. The important is the fallopian tube, mucous membrane. And mucous membrane has got 3 important things. It has got cilia to help the embryo and the womb to transport. It has got secretory organs, that is, it will secrete the fluid, which is a nutrient to the early growing embryo. And it will also help the embryo to grow in first 1 to 2 days. And that is the beauty of the fallopian tube, what the work it does. And when it is doing that, we have to evaluate that. But unfortunately, we don't have any investigation. But in these, the PID is the main cause. And again, the obstruction can be at the proximal obstruction, can be distal, it may be unilateral, it may be bilateral. All these in the critical evaluation we are going to do. A very important next is the peritubal adhesion. These peritubal adhesions are because of the infections in the abdominal cavity, more of a surgical in origin, like appendicitis, peritonitis, septic abortion cases, or even ectopic pregnancy. They all produce the damage of the tube. And very rarely, the congenital anomalies of the tube may be a cause for developing the problem in the block. However, many times the family planning procedures are done and tubes are blocked. And there, whenever there is an infertility, a recanalization can also be done. These are all the major causes for any block in the fallopian tube. Now, I request Dr. Sunita to present her the sonosalpingography as a mode of critical evaluation, and what are its advantages, what are its disadvantages, how the procedure can be done, can it be done in every clinic. And at the end of Sunita's talk, I will assure you that everyone will do a sonosalpingography, which is so simple and which is so cost effective, which is just takes 10 minutes away from you, that you can, in the very first visit only, when you do a scan, you can also include your sonosalpingography. It will give you, and once you are confident that your patient has got normal tube and normal functional tube, the success rate will go very, very high. And just to tell about the incidence, the cause of the tubal factor, earlier they used to quote very high, 40 to 50% is the cause for infertility. Today it has come down because we have controlled the infection to a great extent. However, till today, even 15 to 20% will contribute to infertility. Now I request the Sunita, and you know Sunita is known to every one of us, and she is professor and unit chief at SDM Medical College, ICOG fellow in minimal access surgery, and HDOGS president, endoscopic surgeon, and fetal medicine and high risk pregnancy are the choice of the subject. More so, she is my very loving postgraduate student, and I have a hand in her obstetric life also. I am proud of Sunita, the way she has progressed in the last 2 decades. Yes, Sunita, stage is yours.
Thank you, sir. Thank you so much, sir. Just a minute, sir.
So,
You can make it full screen, I think, doctor.
Yes, sure.
ಒಂದ್ಸಲ ಬಂದ್ ನೋಡೋಣ.
Good evening, one and all, the great visionaries of Kasoga and KCOG. It gives me immense pleasure to be here, to be a part of this academic feast. Dr. M.J. Hirabat sir said, yes, I'm very happy that you invited me for this talk, and I'm very happy to share my experiences. When I did my dissertation along with sir, he was sure that he is going to give me this topic, sonosalpingography, followed by laparoscopy in the evaluation of tubal factors in infertility. Initially, I was actually jittery. I was worried like how I'm going to do, but I knew sir was quite popular then, even now, and I was sure he would have thought of it and given. So we started doing, and within 6 to 7 months, I finished 50 cases, and it was such a cakewalk. Sir encouraged, he himself did so many laparoscopies for my cases as well as the junior staff, and we could, without any hitch, complete. So I proudly present here today my dissertation. Thank you for this opportunity, sir. And we could prove that sonosalpingography was very effective in the initial workup of infertile patients in comparison to the gold standard, that is the laparoscopy. So as sir mentioned just now, evaluation of fallopian tube is an essential part of evaluation of any infertile couple, as it accounts for 30 to 35% of infertility patients. Now we have many gold standard, as we all know, to remind ourselves. It's the hysterolaparoscopy, but I feel we should not do just for the sake of diagnosing any pathology in the uterine cavity or in the tube. We should not be jumping and doing the operative procedure, that is diagnostic laparoscopy. If we have to add on with any surgical procedure, say for example myomectomy, polypectomy, or endometriosis, cyst adhesiolysis, then of course it gives a lot of benefit to the patient. But just for the sake of diagnosis, I feel sonosalpingography should be the first investigation in the armamentarium of tubal patency test, as we have the gold standard HSG as well, as Dr. Mahesh will surely impress, I'm sure. But I feel SSG should be the first test to be done in patients who come with infertility. Now, what is this? It's a simple procedure for testing the tubes, similar to HSG, done under transvaginal sonography. I'm sure no pelvic examination ends today without a TVS. So just an extra step ahead, put sterile Solen, of course, with consent. It can also be used to investigate the endometrial cavity. So it's no doubt it should be the first, after a thorough history and examination, transvaginal sonography in infertility patients. Sonosalpingography will help to a great extent to evaluate the uterus and the tubes, and not only in tubal evaluation, but also as a part of ART, assisted conception. We can evaluate the endometrial cavity, just like how we do the hysteroscope. So in abnormal uterine bleeding can also lead on to infertility. For example, adenomyosis, polyps. See, the recent armamentarium is adenomyosis has been causing important, we see a lot of patients with infertility having adenomyosis. And this new thing of sonohistography is going to pick up biometrial lakes and slides, which will tell us the clue that this lady must be having adenomyosis, which is very difficult sometimes by just doing transvaginal sonography. Of course, we can have MRI to confirm, but sonosalpingography adds on and gives a good clue to what the patient is having. Patients with submucous fibroids, polyp also can be identified by the sonohysterosalpingography. And patients with recurrent pregnancy loss, we can evaluate the cavity. It could be Asherman's or it could be septum, which is missed. So adding on to that, and oligomenorrhea, amenorrhea, again, Asherman syndrome can be well evaluated by this procedure called as sonosalpingohysterography. Now, there are no much contraindications. As it's simple, it's just active infection and it's an undiagnosed ongoing pregnancy. So it's better you do a urine pregnancy test if you have any doubt. And of course, treat the infection and only then embark and do the tubal patency test. Now, why we should think of evaluating the tubes? Because normal healthy tubes are not visible. And so when there's fluid inside, we can see the tube. So this is utilized in sonosalpingography. And when we fill the uterus and the tube with saline, so we can better visualize. And this is what is the concept of this sonosalpingography. Now, this is popularly called a Sion test. When Sir gave me this registration, this paper had come in the Foxy Journal, done by Dr. Gautam Malhabhadia. Sir told me, go see that article, bring, and just we will do this. We'll take that as our target study and we'll do. So this Sion is the place in Mumbai where Dr. Gautam Malhabhadia popularized this test called as sonosalpingography, which uses, again, I repeat, transvaginal sonography to confirm the patency by visualizing the turbulence near the fimbrial end when a mixture of saline and air is injected through a Foley's catheter inside the uterine cavity. Now, this is the concept. By doing a transvaginal sonography, we can see the waterfall sign, the turbulence flowing out through the fimbrial ends and gets collected in the pouch of Douglas. Now, adding on to this contrast nowadays, there are many generation contrasts. So that's add on to the information provided by simple, instead of just putting saline, if you add on this contrast, the added value will be too much. We can appreciate the fimbrial pathology, the endometrial pathology beautifully, much better than probably at par with hysteroscopy. Now, this picture is self-explanatory. So beautifully, we can see here the tube with its finger-like projections of the fimbria. So if you can see such beautifully with this SonoView contrast second generation dye, and this is the ovary, and a lot of fluid has come here. So it tells us that it is anatomically patent and there are no peritubal adhesions because we can't see any bands here. So we can understand the biological function of the fimbrial projections of the fimbria. So this is the beauty of doing sonosalpingography with dye. So this explains that this should be the first investigation when we try to find out that this lady doesn't have any tubal pathology, may help us with simple ovulation induction or any other thing. So now this is the Sion test. It's instruments, we just need this Foley's catheter number 8 with a 20 ml syringe. Procedure, it's better to do after on day 7 to day 10 of the menstrual cycle. Of course, you should take informed consent. It's better you allay the anxiety, counsel her that it will not pain. You can give her, if she is anxious, you can give her some anti-inflammatory. And of course, a short course of antibiotics, doxycycline or any other of your this one. So only preparation is just keep the, ask her to empty the bladder. Now, this is a small video in our infertility center. We do it every day. A 1-minute video. This is the bulb here, trying to fill the uterine cavity. Now you can see the ovary. The fluid has started to come. It will just take, as Sir mentioned, MG Sir mentioned, it takes just 10 minutes. In the office, your ultrasound room itself, you can do. The fluid has started to come. So it is in 2 minutes, the entire POD is filled with fluid and the fimbria fallopian tube is floating. So we can so beautifully understand the anatomy there. To a great extent, we can understand that there are no adhesions, peritubal adhesions. Look at the beauty of the cavity there. So there are no obvious polyps or any submucous fibroid or septum. So within 10 minutes, we know that her tubes are functioning. There are no obvious peritubal adhesions. ovaries look PCOS. So we can define this infertile patient into a low risk category and plan the treatment.
Thank you.
So sonohysterography allows identification of the intracavity lesions as well as the patency of the tube, functional as well. So if you think it's a thickened endometrium, so when you put the saline, you know it is not the thickened endometrium, it could be a polyp. So we could do the corrective procedure, which will enhance her fertility as well as solve her abnormal bleeding. Submucous leiomyoma can also be sometimes there will be doubt by doing simple transvaginal sonography, whether it's a polyp, fibroid, or a thickened endometrium. So this helps us. Now the benefits, again, I repeat, it's an office procedure, low technology, low cost, and I'm sure all of us have a transvaginal ultrasound in the OPD. Better resolution ultrasound is a boon nowadays. It's well tolerated, no radiation exposure, very important here. HSG has radiation exposure, though it's less. Each tube can be assessed separately, especially with the use of dye. Provides an accurate and more complete assessment of the uterine anatomy, just the interest of the person who does it and how well he studies. I'm sure if you do a good sonohysterosalpingography, you can avoid doing a laparoscopy, at least in the first 5 years of infertility when there are no other obvious causes in a young patient. Of course, there are not much of adverse events. I'm sure a lot of patients will have mild pain, so better give an antispasmodic before the procedure. And this study has been well studied, and sensitivity and specificity is quite good as nearing 100%. And it is compared to our standard HSG. It is at par with that, almost 99% and 100% sensitivity when compared to HSG. So to conclude, sonosalpingography is an inexpensive, non-invasive, simple screening test that should be done by every gynecologist as an initial workup in patients with infertility, abnormal bleeding, and so on. It has got it. I was preparing for this talk. There's a lot of research done in patients with adenomyosis as well as other causes of abnormal uterine bleeding. Thank you. Thank you so much. Thank you for your patient hearing. Thank you, sir, for this opportunity. Again, at this juncture, sir is, as Sonia, sir is a great teacher. Every PG is fond of sir, and so I was sure, because he was my guide, I was very sure that I was one step ahead and I could do my post-graduation with so much ease. And I'm sure his blessings are there with me. And I remember him every day for his encouragement, constant encouragement. Every time I would say I'll post laparoscopy sir next week. Yeah, sure. He would see that no case gets cancelled. And it was like a real sail through for me. And at this juncture, I thank you, sir, for your loving guidance and your affection towards me. Thank you so much, sir. Thank you, all other visionaries in this webinar. Thank you so much.
Thank you, Sunita, for a wonderful presentation. And you have made so simple and so much clarity in your talk. I hope everybody will accept and everybody will start doing this sonosalpingography, because this is very, very simple. And cost is almost not involved, because you are doing already an ultrasound to your patient. And in the very first visit also, you will be able to get. I do a lot of sonosalpingography, and in all the infertility patient, this will be the first investigation. And so beautifully, Sunita has explained, it is not only the fallopian tube, it will identify even the uterine cavity, where she has shown how a polyp can be seen. And she has also shown beautifully ovaries, so beautiful ovaries with all the follicles. And even you can measure the follicles so beautifully, because you have a contrast of saline. Without a saline, the ovary visuality is not so good. But here, when you put the saline so much into the pelvic cavity, the ovaries look beautifully, and so beautiful presentation, Sunita. And now, for anybody has got any questions, they can ask Sunita. She will be definitely answer all your queries. For next 5 minutes, there will be some discussion on this topic, and we'll go to the next topic. Yes, any questions? Sonia?
Yes, and I had actually one question in the chat box, Dr. Sunita.
Yes.
So if you feel that there is an infection, vaginal or cervical infection, do you actually do a pap smear and then take it forward for the procedure?
Yeah, you could do a pap smear, but I think if there is infection, better treat it, and then I think you can do it in the next cycle. If you feel that there's infection, better don't do any procedure like sonosalpingography or HSG or anything. Give it some sorts of antibiotics and then bring. But I think pap smear would be fine because it's such a patients don't come again and again. But infertility workup can be held, but doing a pap smear, I feel it's okay.
Okay. You did mention about the peritubal adhesions, visualizing that.
Yes.
As per your thesis, your study, how many cases have you recognized of peritubal adhesions?
Yeah. There were 2 patients of tuberculosis actually. She was a silent tuberculosis patient. We did SSG, it showed tubal block. Then we posted her for laparoscopy. That was the one. So there were pelvic adhesions and all that. So SSG could correctly identify tubal block in such a patient. And when we posted for diagnostic laparoscopy, we picked up and we got the endometrial histopathology as granulomatous. Yeah.
Sonia, when the saline is put into the uterine cavity, I think there was a question how much of saline you are going to
yes,
put.
Sir. Next question was that.
The saline is around 200 to 300 ml is more than enough. And when the saline gusses into the uterine cavity, the fallopian tube will get pressure inside. Because of that pressure, the fallopian tube starts moving.
Yes.
If you have a mobile fallopian tube, then there are no adhesions. If your tube is not moving at all, that shows that there is a peritubal adhesion. And if there are severe adhesions, the tube will not move at all. The movement of the tube is very, very important. And even the Sunita has shown you how fimbrias are moving. That live movement of the fimbria can be seen. That is the beauty of sonosalpingography, which you will not get in HSG. Because in HSG, what you do, the technician will take the X-ray and he will bring the X-ray to the radiologist, and radiologist will see the X-ray and write. Here, as a clinician, you are going to see the functional capacity of the fallopian tube. I think that is the beauty of the sonosalpingography, what Sunita has done.
Yes.
Can I say, Dr. Sunita, that was a simple procedure put across very clearly. And in my practice, I do the sonosalpingography myself. Like as Dr. M.G. Hiramat said, it gives us the opportunity to not only do the transvaginal scan, see the uterus and the ovaries, and we ourselves as clinicians can visualize the tube, and it has been given quite successful results in us. And the other point I would say is, of course, HSG is going to be complementary. We do it along with that. It is not, they complement one another, but especially in secondary infertility cases, like they come to us, they've had one child and 3-4 years they haven't had, they come. I think very often when we do just a simple SSG and we send them home, most of them, few of them do come back pregnant in the next cycle. Because small mucus plugs or some sort of distortion is done away with. We have a few questions in the chat box. Sonia, do we take them now?
Yes, sir.
Yeah.
Sir,
Yeah, so,
can we take the
We'll take later. They will take all 3 at a time. Just I initiated this to make it more lively.
Okay. There are two questions.
Only 2 questions can be taken up.
So any complications, Dr. Sunita, you have seen in SSG? If so, what?
When I was doing my dissertation, I didn't have any complication as such. In this routine practice, also no major complications, ma'am. Nothing. Okay. It is so easy. Pain can be just allayed by your counseling and any antispasmodics.
Yeah.
No,
so what I do sometimes, if the patient is very apprehensive, we just put a Zonac, diclofenac suppository 15 minutes before the procedure.
Yes, ma'am. Yeah, that is.
And, yeah, what kind of patient, Dr. Kubera wants to know, what kind of patients you find it difficult to do? And are you using the 3D inversion mode in your SSGs?
Maybe I think at present we are not using 3D, but there's a lot of research done there, and it gives a lot of first-hand information. Especially I showed you the fimbrial end, that gives a good add-on to anatomical and biological function of the fimbrial pathology and function. Which case it is difficult. I think cervical stenosis. Sometimes the catheter doesn't go easily. So in such a case, maybe probably if you can put a misoprostol, ask her to come with 200 microgram misoprostol 3-4 hours before, probably that will help. Sometimes it's difficult to negotiate a very small, tiny cervix. That's it.
Yeah, thank you, Dr. Sunita.
Shall we proceed further?
Yes.
Whether Dr. Mahesh has joined, I am not
Yes,
able
sir.
to see him.
Yes, sir. Dr. Mahesh.
Dr. Mahesh,
Yes, sir, I'm here, sir. I'm here.
yes, you have finished your surgery.
Yes, sir. I'm
It's
here.
a pleasure to have Mahesh as one of our panelists. As all of you know, Mahesh is our EC member of Kasoga, very active member, and he is an IVF and infertility specialist. Day in and day out, he is looking at the HSGs and deciding what way to go ahead. And past secretary of PSOG, member of KISAR and ICOG, and he is almost he is moving everywhere. Whole of South India, he is carrying his infertility when he became the chairperson of infertility committee. And I thought that he can give a lot of light on this hysterosalpingography, which can be used even now. People thought that once the laparoscopy, hysteroscopy came into picture, there is no use of HSG at all. I think Dr. Mahesh will bring that light that in spite of having hysteroscopy and laparoscopy, HSG has got a role. Yes, Mahesh, it is yours.
Thank you, sir. Thank you for your kind introduction, Hiremat sir. And I'm happy that sir has invited me for this thing. And HSC has always been close to my heart because HSC is a very simple test done everywhere, even in a tier 3, tier 4 cities. But only thing what pains me is the lack of interpretation of HSG. We depend on the radiologist's view. We see the report first. I always say, don't see the report, see the HSG film first, and you will be more than happy to diagnose so many wrong things which have been done by which have been identified by radiologists. So always you read your own HSCs. Always read your own HSCs, and you will be more than happy. So I think you can see my slides. Yeah. So HSC is a simple test wherein these are the few indications what it can happen. It could be infertility or recurrent spontaneous miscarriage, congenital anomalies, postoperative evaluation, or to tubal occlusion. Or you should not do it certain cases wherein if you're suspecting a pregnancy, acute infection, vaginal bleeding, recurrent DNC, or immediately menstrual phase, or tubal surgery is done within 6 weeks. So this patient preparation is generally done within first 10 days is the most ideal phase to do it. After the menstrual blood flow stops, and always take a consent because there's a possibility of spasm and possibility of even cardiac arrest. Always take informed consent, though it's a small procedure, and ask them to empty the bladder immediately before the procedure, and film can be taken. And tenaculum is held if you are facing a difficulty, and ideally you should take 4 spot films because you will not know whether initially there was a filling of the tubes or it came little late with the excessive pressure that you need to put. So it will tell that there is a tubal disease which on pressure you are trying to dislodge, and again it might become stenosed. So these are the things you can learn just while doing. Forced films are much better. You can have certain small complications like pain, infection, bleeding, and sometimes vascular or lymphatic intravasation. So I will not go deep into history because I want to show more slides to you. And these are the media used. These are the instruments that are required. And these are different cannula that can be used. So I don't want to go deep into this one because this can be found, but I'll show you more pictures. So normal HSC, you should be able to see a nice triangular contrast filled uterus. And along with that, a nice pelage in the HSC. So why I say 4 films should be required? Because you see here first early filling phase, and then slowly uterus is descended in the second phase, and tubes are filling and a peritoneal spillage. This is a proper view how the 4 stages will go and how the spillage should happen, and you will know that each stage is done beautifully and each pathology is delineated. So detectable pathology, what do you see? You can see even the fibroid, adenomyosis, endometrial polyp. I'll show you films for all this what I'm showing here, so that you have more clarity. So you can see so many pathologies. I'll show you the films going forward. So you can find non-pathological findings. It could be air bubble. You might get confused with the polyp, a normal myometrial folds, a prominent cervical glands, or previous LACS scar. So luminal filling defects like air bubbles, uterine folds, synechiae, endometrial polyp, or submucosal fibroid can be found. So you can see an air bubble here. So this spot radiograph shows that air bubble which is not yet escaped. So you can see here more clearly. Why I said 3 spot films, 3 to 4, because here, can you see a round lesion, a red lesion? So this round is there in this, but then it disappeared in the third film. So this was an air bubble. That's why a sequential films will help you to identify this filling defect is not a fibroid nor a polyp. This is an air bubble which has disappeared. So this is how you should see. These are uterine folds. If you see linear folds, it will take a little bit more towards in the beginning of the secretory phase or during secretory phase. That's why you'll see more of a uterine myometrial or the endometrial folds. So these folds are normal. So you will see prominent cervical glands. Can you see the radiopaque structures adjacent to the cervix? So even the cervical glands have been filled with the dye. You are able to see a beautiful cervical glands. This is a previous cesarean scar. So if you notice this is a small cesarean scar. If you do an ultrasound correlation of isthmocele with the HSG, so this will give you a fair idea. Other day in another webinar, I was speaking on isthmocele, that is cesarean scar defect. This is a cesarean scar defect. You can identify a pathology on HSG itself, a simple test. So these are the anomalies of uterus which have been classified by American Society for Reproductive Medicine, ASRM. You will see these are the different classifications. You see this is a typical HSC which will show you a unicornate uterus. There is one cornea, one tube and one spillage. Again, you see a unicornate uterus. So the banana shaped here, you will see one tube and one side of the uterus. So you will see sometimes uterine diadelphys. You can see a uterine diadelphys wherein there are 2 different cornua. You can see different bodies and then fallopian tubes with separately wide angle displaced. So this is a bicornuate and ulicolis wherein there are 2 uterine cavities and 1 cervical canal. You can see 2 uterine cavities and 1 cervical canal. You will see bicornuate bicolis, which is wherein always try to measure the angle. If the angle between the 2 cornua is more than 110, so it goes in favor of a bicornuate uterus. So it's a very typical. You can see the black arrow, which will show you a bicornuate pathology here. It's a bicornuate uterus again, shows remarkably splayed horns. Splayed horns, the angle here is more than 110 degrees. So you can certain if it was a were to be a septum, this angle would be less than 75 degrees. So this is how you differentiate between a septate and a bicornuate uterus. I can see a uterine diadelphys, uterine bicornuate bicolis. You can see a DES, diethyl sylvester related uterine anomaly. That's a T-shaped uterus. Earlier it was quite prevalent. Now you don't see them much. This is an arcuate uterus. You will see a small saucer shape. It's not deep like a septum, but just a saucer shape. There's a slight dimple. So this depression of uterine fundus goes in favor of arcuate uterus. Very common to find a septate or a partial complete uterus. So other day I was discussing in my group. So this is the one you will see very commonly. So the septate uterus, you will see this is a complete septum here. Can you see this? Because the angle is less than 75 degrees, you will see a complete uterine septum, and such uterus, if cleared, can conceive normally and no miscarriages. So this is again a septate uterus. So I'll try to show you a angle here. Can you see the angle? Less than 75 degrees. So this is a differentiate. How do you do a differentiation between bicornuate and septate uterus? So in bicornuates, the fundus indicted cavity is more than 100 degrees and partial fusion of the ducts. In septate, normal external surface cavities are close together, that is less than 75 degrees, and defect in resorption of the midline septum. So this is how, and if you see, draw a line, the intervening cleft is more than 1 centimeter and intercornuate distance is more than 5 centimeters in cases of a bicornuate uterus. So this is the differentiation between a septate and bicornuate. It's less than 75 degrees for a septum, more than 105 for a bicornuate uterus. So please remember this. HSC can very clearly differentiate. Can you see a septate uterus here? So beautifully, this can be delineated. In very few cases, there could be confusion when the angle is between 75 degrees to 110, then there can be certain difficulties. Otherwise, very clearly, you can make a bicornuate uterus. This is retroverted. You can see the angle more than 110 degrees. So these are the cases, and this is how you should differentiate. Always a lot of questions are asked, how to differentiate. So this is how you differentiate when you draw a fundus, the contour. straight line between the ostia, whether the depression is down or it is up, and what is the intraosteal distance should be less than 5 centimeter in case of septum. If it is in case of bicarbonate, it will be more than 5 centimeters. So these are the things, very important slide to remember. See, and ultrasound, if you correlate, you will see there are two different cavities here and the bicoordinate uterus. This is how you make out. This is a bicoordinate uterus again. Can you see it's a widely splayed, but here the angle is less. So this is how you make out a bicoordinate uterus. Can you see here a bicoordinate uterus even compared with the 3D ultrasound? So then you can correlate along with the either histolaparoscopy, wherein you can see a partial septum here and a broad fundus with the septum. So septum is a complete septum, and second one is a partial septum, which is quite commonly found. And this is a hysteroscopic image of septal resection. And this is a very important HSG. You cannot forget this ever, because this is a moth-eaten. Like, can you see irregular this one? Outline on the fundus. This is a adenomyosis patient. Sometimes you'll be wondering what is this? These are the extension of the uterine endometrium into the myometrium here. That's why you find a irregular outline. This is because of the multiple diverticulum which has arisen because of the adenomyosis. So adenomyosis can not only be diagnosed by ultrasound, but if you're good, even HSC can tell you about adenomyosis. And you see a fibroid uterus, you see a filling defects here. So these are the filling defects. You have a large filling defect here, another filling defect here. So these are the multiple filling defects you are going to see. And you can see a submucous myoma here on the right wall. So these are HSG itself will tell you even the size of myoma, location of the myoma, if you read HSG well. So another problem you can encounter frequently, especially in infections or tuberculosis, as Dr. Iramat was telling, in a lot of infections, you will see SI and salpingitis isthmic nodosa. That is outpoaching of the isthmus in one or both sides. You can see here SIN. You can see both sides SIN, small outpoaching or diverticuli arising from the fallopian tubes. And you can see SIN here. They are like a small bead here. Number 1, number 2, number 3. There are small outpoachings are there on the fallopian tube. And here you will see a hydrosalpinx here. This will commonly occur in the tuberculosis with the hydrosalpinx one side or both sides and along with the SIN. So these are the kinds of pictures you should be aware of. And this is again a hydrosalpinx. You can see a snake-like structure. Hydrosalpinx are very commonly seen, but normally the radiologists report these things as a normal. There is a spill. If there is a spill, they'll say it is normal. Always look at the character and the bulge and especially a distal dilatation. These are very important along with the peritubal adhesions. So you see a peritubal adhesions here going up, and here you see a small tubal polyp. So there is a polyp here, so there is a filling defect. So you can see even the tubal polyp you can diagnose by HSG. Can you see a right tubal polyp here? Only this area is not taken up, not filled. So this is a tubal polyp on the right fallopian tube. Again, this is a left hydrosalpinx. So because tubal ligation is done properly here, it is not formed of hydrosalpinx on the right, but the left you can see a nice hydrosalpinx. So all these you can make out just by a simple HSG. You can see a tubal ligation proof. Both sides there's no spillage. You can see a nice tubal ligation here done by one of the doctors. It's nice tubal ligation pictures. And this is a peritubal adhesions. If you see peritubal adhesions, generally they are adherent, and then even if there's a spill, it's a localized spill. It's not able to trickle down. So the tube may be patent, but then the dye is not able to trickle down. So these are the peritubal adhesions which you should be careful about. And you can see again left tube peritubal adhesions here. They are stuck. So the fluid, now the dye has come out, it is not able to come down. So you can see a small SIN here, salpingitis isthmic nodosa also along with the peritubal adhesions. So these are the things you should always keep in mind. And here you will see a cervical gland also. If you notice near the cervix, you are seeing a cervical gland here. So Seneca or intrauterine adhesions are very important. Asherman's, not if even if exact Asherman's, lot of intrauterine adhesions you will see in today's practice because of the filling defect. You see it's like almost moth-eaten here. You can't see whole outline itself. You can see top, nothing is there, and even inside it's all like a moth-eaten appearance. So all these are different types of HSG showing Asherman's or intrauterine adhesions. This is a hysteroscopy showing you different views of adhesions. So you can see different views. A scissor is used and which is good enough to cut it. you see a central big filling defect, which is again a nothing but a synec, that is adhesions. So again, you see this HSC. The HSC shows so much of almost nothing is there. Inside everything is torn off. Such kind of a severe synec you can make out only by HSC, and you can convince the patient. So this is one of the simple tests, and intraabdominal adhesions like this on hysteroscopy, if you see, you can clearly cut them and make the corrections. So sometimes there's a coronal spasm. Though the dye has entered one side, other side may not enter. And the left coronal spasm here, if you can see, right side it has the spill, but left side there is no spill. And the fallopian tube ligation, both sides it is done clearly. You can see the dye is stopping at one side. And these are the vascular intravasation. Please remember, whenever there is a fallopian tube is not very patent, if there is lot of pressure used, it will intravasate into either a vascular or a lymphatic. Here you see the arrows I'm showing you, vascular intravasation has happened. Here the HSC, I was shocked to see whether it's a HSC or it's an angiogram. It looks like a pelvic angiogram. Can you know why? You can see the different venous architecture around the pelvic. You can see it is entering the vein and it is going up both sides. You can see a very clean vasculature, capillaries you can see. So such a HSC, because of the tubal, it was not done because of tubal obstruction, it has gone into vessel veins, and you can see such a intravasation into the veins. It's a vascular intravasation, a very nice film. And this is a lymphatic intravasation. Can you see a small spider web-like appearance here? Because of the pressure, the dye has entered into lymphatic system. So please remember, this dye is not a normal HSC. This is a lymphatic intravasation. What you're seeing like a web here, spider's web. So this is a bad HSC. Along with that, there is a, on the superior aspect, there is a intravenous, that is a vascular intravasation. This film shows a lymphatic as well as a vascular intravasation of the dye, which is a complication of the HSC because of the obstructed tubes. This is a tubal occlusion done by a micro insert for tubal sterilization. So genital tuberculosis is important. Please remember, you look for fallopian tubes which have a beaded golf club, pipe stem, cobblestone, leopard skin. All these are in the book. I'll show you the film for all of them, and hydrosalpinx and uterine effects. See, this is a tufted tube. So tufted tube is a multiple small diverticular-like. Can you see here? A diverticular-like in the fallopian tube. This is because of the caseous ulceration, which gives outline like a rosette appearance, and it's called as a tufted fallopian tube, which is typical of tuberculosis. And this is a salpingitis ischemic nodosa I was telling. These are the SINs. And this is a cotton wool plug appearance. Can you see the HSC, how it is like a cotton wool plug? Just for demonstration, I've kept a cotton wool plug here. This is how it looks like, cotton wool plug on the both side. This is distribution of contrast medium in a reticular pattern. That's why it produces a cotton wool. This is a tuberculosis, what I'm showing you. This is again beads. So can you see beaded appearance of the fallopian tubes? So this multiple constrictions along the fallopian tube will give you a beaded appearance. This is called as a beaded fallopian tube of tuberculosis. And this is a golf club. So I'm sure some of you must have played golf or saw golf. Can you see how it looks like? A golf club. So the circulation of the distal portion of the fallopian tube will give you a golf club tube appearance. And it's a pipe stem appearance. So if you see old movies, there's a pipe stem cigar. So you see a similar picture on the both sides because of the extensive adhesions, and inside there's a fibrotic lesion, typically a fibrotic lesion which is not moved. So this is a typical HSC of a tuberculosis pipe stem appearance. This is a floral appearance. This looks like a flower. It's like a bloomed flower because there is a spill here. It is not able to go anywhere. It is just stuck. So again, you see a Asherman's here, intrauterine adhesions here. Can you see in the uterus? There's intrauterine adhesions along with the floral pattern of the fallopian tubes. This is again a severe tuberculosis affecting the uterine cavity as well as the fallopian tube. This is a leopard skin. Leopard is a cheetah. So now if you go to Tirupati, you will encounter a cheetah, is what the news says. So you can see here in my HSC that there is a cheetah skin appearance. That is, you can see a leopard skin. So this is again granuloma, intraluminal granuloma formation within the hydrosalpinx over a long time, which will give light to a cheetah skin appearance. So this is a cobblestone appearance because there's a lot of scarring over a long time inside the fallopian tube. It will become dilated, fibrosed, and will give you a radiological feature of a cobblestone appearance. If you see here on the arrow mark, this is a cobblestone appearance. And this is a corkscrew appearance. So this is a corkscrew used to open the champagne bottle. You see now both have gone so up and they have joined on the up, such as extensive peritubal adhesions on the both side. And if you see here, this is called as a, if you observe a lot of HSCs who come like this. So this is called as a corkscrew appearance because vertically fixed tubes because of the dense peritubal adhesions, and you'll see a corkscrew-like appearance. So this is a typical of an, sometimes PID also presents or tuberculosis also presents like this. A peritubal hollow, can you see the tube? And then there's a hollow here because of the edema and because of the extensive dilatation of the tubes, you find this kind of a hollow around the fallopian tubes, very typical in case of PID or non-typical tuberculosis. Tobacco pouch appearance, again you have read in the textbook of Datta, tobacco pouch appearance, this is how it looks like, a terminal hydrosalpinge which is dilated with the content, either it could be pus or it could be fluid, it produces a tobacco pouch appearance. And this is a intrauterine adhesions. Can you see the uterus here into split and parts with so much intrauterine adhesions? And again, this is a golf club tube. Can you see here? Both side golf club tube along with the extensive synechiae here. So all these you will find in tuberculosis. Can you see a pseudo-unicornuate uterus? Actually, this is not a unicornuate. This has been converted into unicornuate because of extensive adhesions. So these extensive adhesions when they are there, you cannot see the cavity beyond it because it is stuck. If you put a hysteroscope also, you'll go only till here. Beyond that, you'll not go because your adhesions are here. So you'll have to literally push inside after dilatation, then you will see the cavity. And this is how a normal unicornuate looks, but this is a pseudo-unicornuate, which is a typical of, again, a tuberculosis intrauterine adhesions. You can see the adhesions in both of these. This is a DES and T-shaped uteruses. And this is a trifoliate uterus. Uterus itself will become like a bilopatra. Bilopatra, what you use for worship, you see a trifoliate pattern of the uterus itself because of extensive scarring, extensive synechiae formation. The whole uterus itself has become like a 3 leaves, trifoliate, which looks like a bilopatra form. So this is how a histoscopic identification of the different pathologies. If you put a scope inside, a lot of histoscopies I do, and I encounter many times pictures like this. You see such a damaged adhesions and such a distorted uterine cavities. So yes, HSC is minimally invasive, available everywhere and much superior. Thank you everybody for your time. I run infertility study group. I request whoever is not in my group to send a message to this number, WhatsApp message. I'll add you to my study group. Thank you, Dr.
Mahesh.
Again.
Thank you, Mahesh, for the excellent presentation. We have a lot of questions at the end. And 2 things just I want to mention before I forget. One, what you said is read version. That is a very important message because we must develop our own way of reading the X-ray. Because radiologist will read in a different way. We read with our clinical knowledge. And when we look at the X-ray with our clinical knowledge, we are better judge. Number 2, you said about 4 pictures. I think it is a must. Just looking at one X-ray, it is not going to help you. At 4 stages, if you see the X-ray, and another one thing I would like to add to Mahesh is that there are now screens are available. While doing the HSC only, you can see at the screen how the dye is flowing at what level. And that will also give you a better picture for you. That is seen by only technician. That screen is seen by technician. But while seeing the screen, like yesterday, when we were seeing the Chandrayana landing, they showed so beautifully on the screen, that made us satisfied. And I will have a lot of questions at the end, Mahesh, but we have one more speakers. After that, I will take the questions.
Okay.
Dr. Silpa, I invite Dr. Silpa. Dr. Silpa, all of you know that she is one of the active member of our Kasoga, and she has done a diploma in reproductive medicine and embryology also. She is medical director of Shanti Cell Fertility Center, Bangalore, and she has served in BSOG in various capacities, right from the EC member to the president. And right now she is the chairperson of our infertility committee, and she is going to enlighten us on the 3rd critical evaluation, that is laparoscopy and hysteroscopy. And later on, I will allow all these 3 speakers to plead for their critical, that why they want their own sonosalpinography, why they want HSG, why they want. I think that will be the beautiful discussion at the end. I request Dr. Silpa to start her presentation.
Yeah. So is my screen visible to everyone?
Yes.
Yeah, good evening, everyone. I thank Hiremat sir for thinking of me when he decided to have this talk. I'm really grateful. I thank all the members of Kasoga today who have joined to listen to this excellent topics on tubes, which is often, I think, forgotten or neglected. So as an infertility specialist and as a general OBGYN, tubes definitely matter a lot. And I will take you through my presentation as to what is the role of laparoscopy in assessing these tube factors. So tube factors in infertility can be because of tubal blockage, tubal adhesions, and because of the hydrosalpinx. So we suspect that there could be a tubal factor in cases where there is a previous history of PID, ectopic pregnancy, or endometriosis, or there is a prior pelvic surgery. So tubal disease can be majority of the times in the distal tube, and in a very few cases, it will be in the proximal tube. So the percentage is 80 and 20, where majority 80% is in the distal tube. And this is what we encounter commonly when we do a sonosalpingogram or a HSG or even a laparoscopy. So this is the classification as to how we classify the tubal factors. It is classified into grade 1, which is a minor disease, grade 2, an intermediate disease, and grade 3, a severe disease. So this, I think, previously the speakers have spoken and told as to how the tubes can look damaged in the sonosalpingogram, HSG and all. So this again tells us that the severity of the damage in the tubes is extremely important for the outcomes, especially in fertility. So once we know that there is a tubal disease, so there are 3 ways in which we can manage. 1, we don't do anything. Second, in some few cases, we decide on doing the surgical management by laparoscopy route. And in majority of the cases, people choose to do a ART, that is IVF. So when in this era of IVF, where we see that within, I think, 5 kilometers, especially in Bangalore, we see around 20 to 30 IVF clinics. So in the era of ART, what is the role of this surgery or laparoscopies in tubal factors? So it mainly depends on a couple of these factors. That is, one is age of the patient. If the age of the patient is less, then obviously we choose for the corrective surgery, which can give her a better outcome. And also it depends on the severity of the tube damage. Ovarian reserve, yes, we need to look for ovarian reserve. And if it is good, then we can look at corrective surgeries. Prior fertility, if it is a proven fertility, then yes, corrective surgeries can give good results. Number of children desired. So as we know, in IVF, we can have only 1 child at a time. So to have multiple children, then tubal corrective surgeries will definitely score over the IVF. The site and extent of tubal damage is very important when we choose between corrective surgeries and IVF. So the distal tube pathology is always better to be managed with IVF, and proximal tube can be corrected to a certain extent with the laparoscopy. So if there is other infertility factors, like if there is a male factor associated, or if there is low ovarian reserve, then IVF is obviously the choice than going in for tubal corrective surgeries. The most important thing among all this is the experience of the surgeon. So because tube is a very fine organ, so the expertise of the surgeon definitely matters for the outcome and how well we do the surgery. Also, these surgeries are known as the fertility enhancing surgeries, where we enhance the fertility by various techniques. Also, if we run a very successful IVF program, then majority of the ART specialists will choose IVF over the tubal surgeries. So as we all know, the gold standard first line test for women with suspected tubal disease is laparoscopy and dye test. This is a gold standard. So if in sonosalpingogram or if in HSG, if
Nana, Amish, I have earphones on.
can we mute these people?
Yes, done,
Yes, done.
done, ma'am.
Yeah.
Done, ma'am.
So if we suspect that the HSG or a sonosalpingogram is not conclusive, or if it shows a tubal block, then obviously the gold standard would be to go ahead with laparoscopy and dye test, of course taking into account the previous factors that I have mentioned. So in laparoscopy, we assess the nature and the site of tubal disease, and also we do a comprehensive evaluation of the entire pelvis, be it PID, be it the endometriotic spots, be it the change in the anatomy of the tubo-ovarian arrangement. And as I told you, through laparoscopy, we do fertility enhancing procedures where the goal is to restore the anatomic and functional integrity of the reproductive organs. The anatomic restoration need not be always equal to functional. So when we restore it anatomically, so we are only rearranging to their respective positions, but functional enhancement or functional this thing is a little different from the anatomic one, where the functionality depends on the fibrosis, intratubal adhesions, damage to the cilia, and also the fimbria. But again, ART consideration is a luxury because the cost of ART is quite high compared to the fertility enhancing procedures sometimes. And in ART, we talk about the success per cycle. Whereas in fertility enhancing procedures, we talk about success per surgery. So that means like once you do the surgery, it is for the rest of the life. And the woman can undergo and have 1 or 2 or multiple children if the enhancing surgery has been done well. So in expectant management, so we have seen this happen very often, wherein the HSG would have revealed that there is a tubal block, where the laparoscopy also sometimes would have revealed that there is a tubal block. But even then, when the patient refuses to go ahead with any kind of treatment, still the patient has been able to conceive without any kind of treatment. So in expectant management, the spontaneous pregnancy is of about 10% in proximal tubal occlusion, but there is no robust data about how long we need to wait and what was the patient groups that was observed where the pregnancy was achieved without any treatment. And women with bilateral block and in poor ovarian reserve and in or in severe tubal factors are the ones who will not be benefited by this expectant management. So tubal factors, again, the reproductive surgery still remain an important treatment modalities, both in proximal and distal tubal disease, as well as for women who wish to reverse the tubal ligation. So tubal ligation reversal, again, I think is now gaining more momentum, because I don't know, I mean, of course, I see more in my practice now, patients requesting for reversal of tubal ligation, especially who have remarried or who have lost their children for some or the other reasons. Like I have had almost 6 to 8 patients who have requested for tubal ligation in 2023 alone. So the indications of laparoscopy being the detail the indications for recommending laparoscopy in cases of tubal factors infertility, and we have to discuss the criteria used for laparoscopic evaluations such as like suspected tubal block, previous abdominal surgeries, and unexplained infertility. So when we come for a surgical management, so we have mild tubal disease and severe tubal disease, where we try to restore the normal anatomy and functional integrity, which depends on the extent of damage of the tubes, which is again dependent with the fibrosis, intratubal adhesions, damage to the cilia, and also fimbria. So the surgical approach mainly is through the careful selection of cases where we can give them the optimal results of successful surgical enhancement of fertility. So in cases of bilateral proximal tubal occlusion, so it could be salpingitis, systemic nodosa, chronic salpingitis, and obliterative fibrosis. So this is once the cannula is near the right corner, I remove the stellate and I insert the guide wire into the corneal end of the tube to enter the tube. So this is a little fine procedure which we have to be careful. And I remove the camera head and the telescope and I go into the laparoscope. I you can see the guide wire. I'm just pushing it into the fallopian tube. So halfway through the fallopian tube, if we push it, it is sufficient. And then I take out the guide wire. I take out the guide wire and I will inject the methylene blue into the cannula gently, as you can see here. And now you can see the spill coming out from the tube. So there is a mild dilatation near the fimbria, but the tube is patent. And on the left side, you can see that the spill is there. So even the left side tube is also patent. Thank you. So this was the hysteroscopic cannulation which we do. And here again, I would like to mention that the HSG showed that there is a right tubal block and the woman was ovulating only on the right side successively for more than 6 cycles. So I had to advise them to go ahead with the hysteroscopic cannulation, which revealed that the tube is open, though there was slight dilatation. In such cases, again, we once we know that the tube is open, so we advise them to go ahead with ovulation induction and if required for IUI, if there is a male factor. And if they don't conceive in 3 to 4 cycles, then again, IVF is the answer.
Yeah. Huh?
So to distal tubal disease. So distal tubal disease will have perifimbrial adhesions with or without associated intra-infundibular adhesions. It can be partial or complete agglutination of the fringes, which can cause phimosis. The serosal covering of the fringes leaving only a small tubal opening, in which the rare instances, the covering is total, leading to a complete occlusion, and prefimbrial phimosis also can be there. So this again leads to hydrosalpinx. And if the hydrosalpinx is detectable on transvaginal ultrasound, then it has got very poor prognosis. This is a 2D image of the uterus on day 9 of the cycle. So this is the right ovary, which is stuck posterior to the uterus. And on the left ovary, there are follicles. This is the tube, which shows hydrosalpinx. It's a retort shaped structure. This is a 2D image of the uterus on day 9 of the cycle. So this is the right ovary, which is stuck posterior to the uterus. And on the left ovary, there are follicles. This is the tube, which shows hydrosalpinx. It's a retort shaped structure. So I have put her on letrozole. And this is the 3D image where I will be taking of the cavity because there is no triple line. So this case was a case of miliary tuberculosis where the patient was in ICU for more than, I think, 15 days with severe the tubercular infection. And then the same infection had spread to the pelvis also. And here we can see that there is a documented hydrosalpinx, which is identified as a retort-shaped structure between the ovary and the uterus. But the right side, the adnexa, seems to be free. There is no ultrasound evidence that there could be any tubal pathology there. So that's why I have gone ahead and done the ovulation induction, and I will be monitoring her to check if at all if she can conceive with ovulation on the right side. So coming to hydrosalpinx again, the clinical pregnancy rate is reduced up to almost 50% because of low implantation rates and low pregnancy rates. So this is a case of severe endometriosis for IVF, married 10 years, previous 2 IVF failed, and with bilateral endometriosis. I have taken consent for bilateral salpingectomy as the tubes showed hydrosalpinx in the ultrasound scan. So here I have cleared the right tube. I have released the ovaries from the ovarian fossa, done the cystectomy, and then I have removed the, I'm removing the right tube. The tube has to be removed till the cornua so that cornual pregnancies can be avoided.
We are not discussing management.
Then I have cleared. Okay. Yes, sir. So,
we are not discussing the management.
okay,
We are
sir.
only what is your take-home message for hysterolaparoscopy as a tool to critically evaluate the tubal factor.
Yeah. So again, I think laparoscopy will play a role only when the HSG or sonosalpingography has any doubts, or when we have to evaluate such cases where endometriosis is also suspected, or when there is a suspect of hydrosalpinx.
ಕಿಡ್ನಿಯಲ್ಲಿ ಕಲ್ಲಿದ್ದು ಅದು ಕೆಳಗಡೆ ಬಂದಿದೆ ಆ ಜಾಗಕ್ಕೆ ಅಲ್ಲಿ ನೋವು ಬರ್ತಾ ಇರೋದು ಎಡಗಡೆ ಇರೋದು ಅದು ಸ್ವಲ್ಪ ದೊಡ್ಡದಾಗಿ ಇದೆ ಕಲ್ಲು ಅದು ಗ್ಲೂಕೋಸ್ ಹಾಕ್ತೀವಿ ಈಗ ಗ್ಲೂಕೋಸ್ ಹಾಕಿದ್ರೆ ಅದ್ರಲ್ಲಿ ಪಾಸ್ ಆಗ್ಬೇಕು.
Please mute all others. Yes, continue, Silpa.
Yes, sir, done.
Dr. Silpa.
Yes, sir.
Please continue.
Yeah. So I think as sir asked, this is again a phalloscopy where the functionality of the tube can be assessed, where the hystomat at 70 millimeter water pressure, where appearance of the cilia is seen with a 2.9 mm rigid hysteroscope. But this is something which is not done very routinely, and I don't do it routinely. So this is only to check the functionality of the tube, but the practicality is very less compared to it. So I would like to conclude saying that, yes, if there is a proximal tubal occlusion, which is shown in case of shown by HSG or sonosalpingogram, hysterolaparoscopy will help by one, identifying if there is definitely a block, or if there is just a spasm which can happen because of the pain. So in such cases, through hysteroscopic cannulation, yes, definitive treatment also can be given. And also in other evaluation of the pelvic diseases, definitely laparoscopy adds more value than the HSG and sonosalpingogram. So with this, I conclude my presentation. So any questions I would be willing to take.
Thank you, Dr. Silpa, for beautifully presenting the histolaparoscopy as a tool for critically evaluate the tubal factors. And two take-home messages what Dr. Silpa has given is, this is the gold standard. But when this is a test is a gold standard, now we will have a discussion at what stage of evaluation we have to each one of them. So in the further discussion we'll be having. In fact, I wanted to have a separate the webinar on management of tubal diseases. Okay, so this I had restricted only for critical evaluation. Now the forum is open for questions, and Sonia has got almost 32 questions in the chat box. Now, Sonia, I request Sonia to ask the questions and request one of the speaker to pick up their question. If it is related to sonosalpingography, Sunita will pick up. If it is related to HSG, Mahesh will pick up. If it is related to laparoscopy, Silpa will pick up. Sonia, just another 10 minutes, Sonia.
Okay, sir. Sir, I think I have an issue with checking the messages. But then what two questions is displayed to me is, I think Dr. Bharti Rajshekar wanted to know from Dr. Shilpa, how do you sterilize methylene blue?
Yeah, yes.
No, we are getting sterilized methylene blue only now, ma'am. So that is what we are using. So I will have to find out from my hospital where they're getting it from. So I will put it up in the group and I will tell it to madam.
Okay, I think
Normally-
madam had to leave.
Just normally, we don't do any sterilization of the methylene blue. The companies who are preparing the methylene blue, it comes in a pack. So it is already sterilized. We need not do sterilization again. That is what is my feeling. What about Mahesh? Mahesh, do you sterilize again?
Yes, sir. No, sir. Methylene blue sterilization.
It comes sterilized and packed only.
Yes.
So there is no need
Yes.
to do sterilization.
No need to
Okay.
sterilization.
Any other,
Only one thing we should remember, once you push a methylene blue, once you finish your surgery, push some saline so that methylene blue should not stay there in the fallopian tube because it might lead
good
to
point.
adhesion.
Good point. And
Okay.
second is, when you are instilling the methylene blue, please dilute it.
Dilution is important.
Dilution is a must. And if you don't do the dilution, there are small particles in the methylene blue, which may produce an adherence. I think that is the one which is a
Any
point.
specific dilution, sir?
In
Nothing
one
specific.
kidney tray, just 1 drop or 2 drop enough. 1 drop or 2 drop of
See, nowadays, even without methylene blue, also you can see the fluid. See, methylene
Yes.
only added to differentiate the fluid which is there in the pelvic cavity and the fluid which is coming out of the fimbria. That is the reason we add. There is no need to make totally bluish.
Yeah, okay, sir.
Sonia?
I think this is very clear regarding the methylene blue, sir. We go to the next question by Dr. Riya Bhattacharya. Peritubal adhesion shown on HSG need to be treated by antibiotic.
These are
Is it a
generally
must?
long-standing fallopian tubal adhesions. These are fibrosis instead of
More of a
adhesions. I should
fibrosis.
say these are fibrosis. Just by antibiotics, they wouldn't do much of a justice. So I don't think much need to be done now. Antibiotics may not help with them.
Yeah, I fully agree with Mahesh. The adhesions which are picked up in HSG, they are totally fibrous. So they are not treatable. Only you have to do a laparoscopy and release the adhesions. That will help. Otherwise, there is no any drug for that. Any other?
Yes, sir. What kind of patients you find it difficult to do? Are you using a 3D or inversion mode? I think this is to Dr.
This question
Sunita.
has been asked to Sunita. No
Yes,
other.
Anit. Yes,
She has
sir.
answered it.
Yes, and she's also answered the next question, how much amount of saline needed?
Yeah, she has already answered that.
Do you
250
recommend pap
200
smear
to
is
300.
already answered. How to
One more
correct?
point. One more point. What I would like to add, Smita. Nowadays, what I am doing is in that saline I am putting antibiotic. See, I am putting antibiotic in that saline, like any of the antibiotics, broad spectrum antibiotic, cefixime and that. When you put the antibiotic in the saline goes into the uterine cavity, directly acts on the infection. This saline also goes into the fallopian tube. So it is locally treating antibiotic, like what we are using metronidazole locally. You put the metronidazole during the laparotomy. Like that, you can add the antibiotic in the saline. That is what I am doing.
Yes.
Okay, probably at the end of the procedure, you can complete the procedure by actually doing this.
Yeah,
Inserting
at
the antibiotic.
in the last spill, you add
Yes.
antibiotic in your saline, maybe about another 20-30 ml.
Okay.
Yes,
I think the next question is how to correct the tubal polyp. We are not actually
no, we are not
discussing about the treatment modality as such now.
That will be a different webinar in due course. I will be arranging a webinar on the management of tubal diseases only, which includes microsurgery, which includes the laparoscopic surgery. Okay.
Okay. Any complications you face so far while doing SSG? I think it is Dr. Sunita.
Yeah, I don't think there are any major complications. Mild pain can be easily managed by giving antispasmodic prior to the procedure. As such, there are no major complications.
Okay. I think most of it is the compliments than the questions. A wonderful presentation by all the three wonderful speakers.
Yeah. So to conclude, I thought that this is necessary because critical evaluation of the fallopian tube has to be done. And when to evaluate fallopian tube is another thing which we all should look for. See, when the patient has come with just 1 year married life for infertility, don't go for fallopian tube evaluation because the major problem there will be anovulation. So we go for ultrasound evaluation. If there is an anovulation, you go for induction. But any patient who is remaining for a long time infertile, maybe more than 3 years, then they need 2 to 3 years. And age is also very important, whether they are between 20 to 30 or they are beyond 30. If they are in the age group of 20 to 30, I think the evaluation, tubal evaluation is not necessary. Right now, Dr. Sunita has told you that the major tubal evaluation has been done while doing the sonosalpingography. That may not necessitate right now to go for HSG and also for laparoscopy. I think long-standing infertility cases, they need to be evaluated, maybe more than 3 years, and go for the HSG and the laparoscopy. Both are very complementary. See, somebody may tell me, no need to go for HSG, let me go directly to laparoscopy. I think Mahesh has enough convinced everyone with his wonderful, the X-rays, that how a HSG, which is so simple technique, which costs so less. Today, on an average, an HSG will cost 2,000 rupees. Maybe in Bangalore, it may be 4,000, but in Hubli, we get HSG done at 2,000 rupees. At 2,000 rupees, you get so much of information, what you would have got by doing a laparoscopy by spending 50,000. And what is the risk of the patient? In HSG, the patient has got low risk, whereas in laparoscopy, when you are giving general anesthesia, the risk is going to be high. So even though it is a gold standard, I think we must go option like this. In legal term, they say that you can't go directly to Supreme Court. If you go to Supreme Court, they will tell you, you go to the lower court. So I also suggest that while evaluating the tubal, you go to HSG. If you are not happy with HSG, you go to HSG. If you are not happy with HSG, if it is not convincing, for example, right now Mahesh has told there may be spasm. Because of the spasm, the report may be wrong. But that spasm will be taken over when you do the laparoscopy. I think it is like stepwise going. So today's discussion has been given us that let us evaluate the tube stepwise with a minimal invasive or no invasive, later on minimal invasive, then actually gold standard, that is laparohistoscopy. Falloposcopy I am not doing. Any of the participants here, if they are doing falloposcopy, I request them to add on this. I think that is the one addition in the critical evaluation which needs. Maybe that the cost is very high. We are not used to do the falloposcopy. Anybody, if they are doing the falloposcopy, please add. Mahesh, anybody is there in the participant? Today, I'm very happy that there are 100 participants today. So that everyone is so much interested in this webinar. So anybody is doing falloposcopy, please add. Otherwise, I request Dr. Suman Gaddi to give the vote of thanks and her comment. Mahesh,
Yes,
anybody is doing falloposcopy, please add. Mahesh, are you doing?
No, sir. It's very rarely done.
Silpa,
For me, I feel HSC
and
is
out
more than enough.
Silpa is
HSC will
doing?
give you all the information.
No, sir. No, sir. I don't do, sir. I don't do the
Not-
falloposcopy.
Okay.
I don't do it.
Now, falloposcopy came 10 years back, thinking that it will be one of the major investigative procedure. But unfortunately, the falloposcopy did not give much information and it did not help much also. And in many cases, what you do is that when you go for falloposcopy, you are not able to reach to the end. Sometimes you go only 2 to 3 centimeters in the fallopian tube. After that, you fail to enter. I feel probably falloposcopy has not become very, very popular.
Yes.
My feeling. Yes, Suman Gaddi, madam.
yes, sir. Good evening, one and all. And first of all, I thank the entire KCOG team for taking up such an important topic. that is Tubal Factors in Infertility Critical Evaluation. And I first of all thank Dr. M.G. Hirmat, who is the Chief Patron of Kasoga and today's moderator. And sir, you have moderated very well and made the webinar so interesting, giving us so many important tips. And I also thank the Kasoga office bearers, Dr. Vidya Tobi, who is the president, Dr. Rashi Paradhi, honorary secretary, and Dr. Bharati Rajshekar, who is the president-elect of Kasoga. And definitely the speakers were wonderful. And first of all, I thank the first speaker, Dr.
Sunita.
Spoke about importance of SSG and the advantages of SSG. And of course, all the speakers or today's speakers, they were pioneers of their respective fields. Dr. Mahesh Korigal, who spoke on HSG, showed wonderful slides and so many slides on uterine and tubal factors. And Dr. Shilpa Jivi, the role, of course,
Yes.
and spoke on the role of laparoscopy as a tool in tubal factors. And then I thank Dr. Of course, Dr. Sonia Mandappa, who is provider.
I think there is an issue with
Sonia,
connectivity.
you
sir.
can also conclude. You started
Yes,
the program. You
Yes,
conclude.
sir. I think Madam has. Yes, Madam, we can hear you.
Can you hear?
Yes, Madam.
Yeah, I'm sorry for the interruption. And I thank all the delegates who have joined in. We had nearly almost 100 delegates today. And of course, they must have really made best advantage. They have really learned so many things today. And then I also thank Mr. Arun, who, of course, for providing the Zoom platform for today. Thanks, one and all.
Yes.
Sonia, last word.
Thank you. Yes, sir.
You started and you ended.
Thank you so much for the opportunity provided, sir. Excellent speakers and moderation was definitely commendable. But then this is a tube factor, which is curvy, bumpy all through. And I think today, Gabriel Phaloppus will be, I don't know, his soul will definitely be very happy to know that there are so many pictures, which was not on the cadaver, but on the live women folk with a huge collection from the cotton wool to the champagne bottle. As in the chat box, Dr. Bharti has mentioned, yes, we need to open a champagne bottle now with Dr. Mahesh's presentation and Dr. Sunita and Dr. Shilpa to add on. And we need the beads, sir. We all women are very happy beading ourselves. And with all the other presentations mimicking the cheetah and the bead and the cotton wool and the tobacco pouch, it made a wonderful presentation. And thank you very much. And this was an opportunity for all the postgraduates and the consultants and a quick wrap-on session with the question answers. Thank you very much, sir. Looking ahead for the Varma Lakshmi.
Thank all of you. Wish you Mahavaralakshmi Day, and all will become richer and richer with this celebration tomorrow. And
yes, sir. And the success of Chandrayaan has also continued with the success of the academic wing of Kasoga.
Thank you.
It's going high.
Thank you.
So
Namaste. Namaste to Ichi. Once
thank
again,
you so
I
much.
thank all my three speakers who have done a wonderful job. Thank you.
Thank you, Suman ma'am.
Thank you.
Yeah.
Thank you so much, ma'am. Okay. Thank you, sir.
Okay, good night.
Good night.